بسم الله نبتدي. العيان اللي جاي بقى بيشتكي من headache. So before we think about causes or before we proceed, we have to know the most common cause of headaches in children. طبعا من اهم الحاجات اللي هتبقى ruled out ان يكون brain tumor. بس brain tumor is not the most common cause of headaches in children. More common causes like stress or tension type headache, stress, migraine headaches. This is very common, very important not to miss it, and we have to explore about it. And acute or chronic sinusitis. And as we mentioned in the previous lectures, acute and chronic sinusitis all diagnosed clinically. No imaging is required to make the diagnosis of sinusitis. Dehydration, lack of drinking water, this can cause also a headache. So the parents, they have to make sure the child when he goes to school drink enough water. Lack of sleep, lack of sleep by itself can cause headache. So this type of questions is very important to explore before you go to major stuff. Excessive exposure to electronics and the eye strains. The children all the time their eyes on the phone, and this can cause vision problem. And I get actually this from not my own opinion, is from ophthalmologists. They said one of the major causes of eye problem and the headaches in the children is electronics and eye strains. So these things are common. Of course, you have to rule out serious causes like intracranial masses if the headache is sudden and severe. Occipital headache. Any headache in the back of the head is always abnormal. No benign headache in the back of the head. And the children, they might not say occipital, they may say neck pain. My neck hurts. So neck pain in the children always abnormal, never normal. So you have to take it seriously when a child says my neck hurts. Early morning, of course, if it's recurrent and progressive, but one time wrong sleep position and after that is fine, I don't think it's a problem. Pain that awakens the child from sleep is serious. Worsening of pain and with change in position or with coughing and sneezing. This is the question we'll ask. If the pain is worse with coughing, sneezing, or straining. Increasing in frequency and the intensity. Signs like a change in mental status, cranial nerve pulse in a child with new onset strabismus, or shifting or drifting of the eye. This is abnormal. We have to think about anything intracranial. Visual field defects, papilledema. It is always a good idea to have ophthalmoscope in your clinic and learn how to use it. Ophthalmoscope, you can see the papilledema if you get used to it. Abnormal papillary reflex with the ophthalmoscope or any source of light, you can see the pupillary reaction. If you see a child with severe headache, progressive, and the pupillary size is unequal in both eyes, the reaction is different, you have to take it seriously. Focal neurological deficit, ataxic gait or ataxia or gait disturbance. So migraine, I will go over migraine because it's important. This is the most common you can see, and you are always dismissive about it, but this is common, and it's important to ask about family history of migraine, and this will help you to make the diagnosis. Usually acute, comes and goes. Duration can be all day long, 2 days, sometimes up to 3 days. In children, migraine always bilateral in both sides. أما في الأطفال في الكبار بيبقى بس ناحية واحدة أكتر. So bilateral is more common in children. Unilateral is more common in adults. Typically pulsating in quality, may be associated with nausea and vomiting, photophobia, phonophobia, vertigo. The child usually will seek a quiet, dark room and will go to sleep, and this will make the headache better. Okay. The aura is more common with adults, less common with children, but they may have it, but it's not common. When to do a prophylactic treatment to migraine headache? When to start the prophylactic, like to give daily medicine? If it's too much for the child, like absent from the school most of the time. So 4 or more headaches a month. Significant disabling attack despite the appropriate acute management. Having contraindication to acute therapy. Acute therapy, if you have someone with mild migraine headache, comes once a month, ibuprofen or paracetamol should be enough. Other things you can use for severe attacks of acute migraine headache, rizatriptan is approved for kids 6 years and older. Same like sumatriptan. but is only once a day. Cyproheptadine, one of the most common medicine we use for to prevent migraine headache, to give it once at night. You start with a small dose, and you have to tell the parents that the effect will show after 3 weeks or after up to 6 weeks. So the effect of the medicine will take time to build up in the system to give you effect. Amitriptyline is, especially if the child have lack of sleep, is a tricyclic antidepressant, but is used off-label to treat migraine. Can be used for also for cyclic vomiting. You can use it only once at night. If the child has an anxiety with the migraine, you can use amitriptyline, will treat both. If the child has problems to start to sleep, amitriptyline will make the child sleep better. Cyproheptadine also can be used for children that have poor appetite, they don't like to eat. This will increase their appetite, will make them eat more. If the child is having allergies with it, you can use you can use the side effect for the benefit of the patient. Other medicine is very common, widely used, topiramate or Topamax. Topamax, you can use it. I usually start with 25 milligram at night, and I give it to them for a week, and I ask them to come back. How is it? And if it's good, we can increase it to 50. So 50 is the standard dose to do at night, once a day. You can do go to maximum twice a day as a prophylactic for migraine. For severe cases, you can do 50 milligrams twice a day of topiramate. Other medications also can be used, like anti-seizure medication like zonisamide or Depakote. Propranolol, you can use it if the child has an anxiety with, so you can use it. It may decrease the anxiety in addition to prevent migraine, but be careful not to use it with children with diabetes or children with asthma. Verapamil also can be used if the child, for example, having borderline hypertension or high blood pressure and having migraine. I can use verapamil, will treat both. Will treat the high blood pressure and the migraine. So I try to use all of the side effects for the benefit of the patient. So the most common prophylaxis used, and we use all the time, is cyproheptadine, to use once a day, and topiramate once a day. For how long to use it? Use it for maybe 6 months or 1 year, and then you can, for the summer, you can try to withdraw the medicine slowly. For cyproheptadine, you don't have to do a slow withdrawal. This one has to be withdrawal slowly, and try to see the child how the child will do in the summer without medicine. So you have a child say, I have a headache with neck stiffness, and he has papilledema, visual field defect, limited abduction of one or both eyes. So what do you think? Huh? No, he doesn't have fever. Idiopathic increase, pseudotumor cerebri. Perfect. So you do the MRI. Of course, when you have papilledema, next step MRI, it must be done. And the MRI comes normal, then the next step to do a lumbar puncture with opening pressure. You see the pressure more than 28 to 30 centimeter of water. This is a diagnostic. And actually, after the lumbar puncture, the child, when they wake up, they will tell you the headache is better because you already took some fluid out. So the treatment of idiopathic intracranial hypertension, avoid triggering agents, weight loss, a carbonic anhydrase inhibitor like acetazolamide. This is one of the treatment of choice to give to decrease the intracranial pressure. Topiramate can be used off-label. So if someone has migraine headache and borderline pressure, high pressure, not to the point to more than 28, most of the neurologists, they can use topiramate because it will work for both. To treat migraine, possible migraine with it, and also will decrease the CSF production and will help with intracranial pressure. So we'll move to another subject. A child coming with muscle weakness and back pain. So this child is having progressive muscle weakness in the lower limb with increased tendon reflexes, change in bowel and bladder control. You saw tuft of hair in the, above the gluteal cleft. What is the most likely diagnosis? Yeah, Dr. Muhammad said tethered cord syndrome. Tethered cord syndrome. So the key points here that you have progressive muscle weakness with back pain or without back pain, and the tendon reflexes are increased, and the change in bowel. Any child with a change in bowel movement or bladder movement and they have accident after they were continent before, you have to check the back. Very important to check the back. So this is tethered cord syndrome. It's important for us to be aware of this syndrome. Why? Because all the damages will be irreversible. So early treatment. So if you see someone has gluteal tuft of hair, a large sacral dimple, they have to do imaging study, and the best not ultrasound, MRI. This will give you the final diagnosis. It will roll out the tethered cord syndrome. So tethered cord syndrome, the distal part of the spinal cord will be anchored into the spinal canal, and as the child grows, they will have problem. The area, the stretch area will become ischemic, and they start to show symptoms. So the best diagnosis MRI, the treatment of course is surgery. You have another child having back pain and muscle weakness, but the pain is sudden, rapid onset, and maybe in the history they had viral infection before. And the sensory deficit and numbness, and there is a sensory level, means the arm and leg, the arms are fine, but the legs is the problem. And there is a bowel and a bladder dysfunction. And this disease affect the spinal cord. And the muscle weakness is usually flaccid, and reflexes are diminished in the beginning. And with time, they start to be hypertonic with hyperreflexia. And CSF, if you do lumbar puncture, will show white blood cells with protein, and the MRI will confirm the diagnosis. Perfect. Transverse myelitis. Another case, progressive muscle weakness in ascending manner with facial muscle weakness and the cranial nerve involvement. Weakness plateau, like the weakness will stop, the progression will stop for 2 weeks up to 4 weeks, and after that they will improve. Mild to moderately severe paresthesia, they start to have feeling numbness and tingling in the hands and in the feet, in the toes. They usually do not exceed the ankle or the wrist. And they have also autonomic dysfunction. Autonomic dysfunction means, like for example, high blood pressure, low blood pressure, flushing of the face, okay, abdominal pain, sometimes they have urine retention, difficulty going to the bathroom for number one, and the hyporeflexia or areflexia, no reflexes, the CSF is showing protein without increased white blood cells. Guillain-Barré syndrome. And the treatment is, what's the treatment? IVIG. And of course, if it's not responding, plasmapheresis. Okay, this one is interesting. I had a couple cases like that. Back pain with limping. The child have back pain and limping. And the limping refusal to walk, especially in toddlers. Toddler may stop walking all of a sudden. Okay, and the toddler may not tell you he has back pain. He may be just crying when you touch his back. And the child refused to pick up an object from the ground. ESR and CRP are elevated. X-ray on the back is normal. Anyone can guess? Huh? Beautiful, beautiful. Yeah, Dr. Ashad is discyrus or osteomyelitis of the back. So discyrus, vertebral body osteomyelitis. Why I put the X-ray negative? Because in the beginning, X-ray may take 3 weeks to show some difference. So the only way to do early diagnosis is MRI on the back if you suspect the discyrus. So the clinical presentation of discyrus, very important not to miss it. I had one toddler before, the case I saw before. This toddler just all of a sudden stopped standing, just doesn't want to stand or walk or do anything. And so the ESR was elevated and the back. So when someone has no problem in the upper limb and the problem is not standing, all of a sudden you have to think about back problems. So MRI is the best study. So flexion of the spine will cause. So usually when I have a child coming and I suspect like old enough, I throw something on the floor. I go, can you pick it up? So if he's not able to pick it up or go down like that, you know that he has a problem with the back. But if he goes like this is the normal behavior to pick up something from the floor. But if he goes like this is make you suspect it could be a discyrus. They may have fever, they may not have fever, and this will make it more confusing. Okay, so it may face fever, and sometimes it has abdominal pain because it may irritate the peritoneum. So laboratory, you will see ESR and CRP elevated. MRI is the most sensitive, and this is in general for any case of osteomyelitis. If you suspect osteomyelitis, always the best study, not X-ray. X-ray you can start with it, it's fine, but negative X-ray doesn't rule out. It takes a couple weeks to have the effect of the inflammation to show regular X-ray. MRI is the best study, and with contrast.
أي age يا دكتور؟
Any age, any age. But if you suspect osteomyelitis and you cannot identify, you don't know where is it, you can do bone scan. Bone scan is the best study. And bone scan for osteomyelitis, one of the investigation for fever of unknown origin. To do bone scan, if someone has inflammatory markers are high, CSF study is negative, everything is negative, and you have no clue why this child is still having fever, and the inflammatory markers are high. One of the studies to be done for fever of unknown origin, bone scan, because you cannot really know where is the spot of inflammation. So you have to start antibiotic covering Staph aureus, length of therapy 4 to 6 weeks, and you follow up with ESR. ESR one of the best to follow up, and you, as you see the ESR is trending down, you know the child is responding. So any child with new onset, day and night urine incontinence and stool incontinence, the next step, examine the back. Always examine the back. Neurological exam. MRI on the back must be considered. Look for hairy patches, sacral dimples, lipoma or hemangioma in the back. Okay, another one very interesting, and most of us we try to avoid these cases, but they may come to you before they go to orthopedic. For me in the US, they cannot go to orthopedic before they come to me first. So here they may see orthopedic doctor, they go directly. But if they come to you, you know what to do with them. Okay. So I will give you just the approach. If you have a child with limping, if there is a history of trauma, especially with a toddler, either witnessed or no witnessed. So the toddler all of a sudden is limping. So mean that maybe the toddler fell down. And the next step is to do the X-ray on the affected limb. If no history of trauma, make sure to include the pelvis with it. Any child with limping, make always sure to include the pelvis with it if you don't know where is the source. And if normal, consider toddler fracture. Toddler fracture, if the child limping on the right limb, you cast the right limb. If the child limping on the left, you cast the left. And for how long to cast? For 2 weeks. And after 2 weeks, the orthopedic will repeat the X-ray, and you will see the healing line. The healing line. But on acutely, you might not see anything on X-ray on toddler fracture. So there is no toddler like 3 years old with limp, and there is no problem. He has a problem. These kids, they will not limp from nothing. They have a problem. So this is the protocol. If you suspect toddler fracture, you just cast the child and repeat in 2 weeks. If you have fever with limp, order CBC, ESR, and CRP after doing your thorough physical exam. If it's abnormal, if white blood cells are more than 12,000, this is called the modified Kosher criteria. If the ESR more than 40 or CRP more than 2, this is significant. Consider septic hip. In septic hip, you will see the limb there is limited range of motion. If a young baby, the mom will not be able to change the diaper without screaming, the child will scream to change just the diaper. If you have septic hip. Osteomyelitis, you will see point of tenderness. I'm sorry. You will see point of tenderness. MRI is the best for osteomyelitis. Consider leukemia in any child with fever and limp. This is maybe I will say a big percentage. I don't remember but a large percentage of children with the acute onset of leukemia, they have fever and limp, they limp. So this can be the initial manifestation. So it's very important to look at the CBC. Look at if you see the platelets are low, this is very likely leukemia. So you can do peripheral smear and look for blast cells. If you have history of previous infection, order also CBC and ESR and CRP, and normal or slightly elevated but less than 12,000, less than 40, less than 2, the CRP, think about transient synovitis. Transient synovitis is triggered by viral infection. And if you give these children, when we give them ibuprofen or any non-steroidal anti-inflammatory, will give you a significant improvement. Okay, so sometimes it's significant enough. The child will be carried by parents. They will carry the parents. I'm sorry, the child will be carried by the parents because they are not able to walk. If you do the neurological exam and the knee reflex is diminished, consider Guillain-Barré. Guillain-Barré syndrome may start with limping and difficulty walking. Limping and difficulty walking. But you have abnormal neurological, you have areflexia or hyporeflexia in this case. So what is modified kosher criteria? History of fever. The child is unable to bear weight or on the affected limb. ESR is more than 40, white blood cells more than 12, CRP more than 20 or 2, depending on the lab if they are using their liter or deciliter. The more criteria, the more likely the diagnosis of septic hip, septic arthritis. So the next step for septic arthritis, not MRI, ultrasound. Ultrasound is one of the best study for septic arthritis. Huh? I'm not familiar with first hour. I see it here only. I need to look it up. What's the difference? Because in the US there is no first hour, second hour. It's only one ESR, one result. But here they have two results. But if I am not mistaken, I will go with the second hour. I will go with the second hour. But over there they do it just one result. No first hour, no second hour. So, but I need to confirm with that. No idea. Yeah. So, yeah. So, but even the first hour, if it's the first hour more than 40, I will consider it. You know, because of the second, so very likely that the second hour will be more. Correct. So if you see the first hour more than 40, I will take it. I will not wait for the second hour because it's already 40. It's already 40. Yeah. So septic arthritis. The problem with the lab here, I don't know if you have a solution for that. That when you send a CBC or test, how long do you get the result back? Usually, it's the following day. If there is any place you can get it in 1 hour.
Yes.
Yeah, perfect. So this is the place to choose if you suspect anything serious, like septic arthritis. It's very bad to wait till the second day. It's very bad to send home someone with septic arthritis. It has to be diagnosed with because because septic arthritis means in the joint it has what? Pus. This pus will destroy the cartilage. So this is called a surgical emergency. So once it's suspected, you have to call orthopedic. And orthopedic, they have to do the irrigation and aspiration. And of course, antibiotic with it at the same time. So septic arthritis is considered a surgical emergency. So if you have this one, my toddler is walking like a duck, tiptoe walking or limping. This can be tiptoe walking or walking like a duck or limping. And she was breached during the pregnancy and positive Galeazzi signs. What is the next step? What to do next? She is a toddler. Huh? And it's, yeah, perfect. Yeah, perfect. So it's DDH, yes. And you can do ultrasound and you can do X-ray. But in toddler, if you have older, you have the ossified center. They will be showing. So you can do the X-ray will be a better option for you. And in young babies less than 6 months, you can do the ultrasound. So you do pelvis X-ray, AP and lateral frag view. This is how to order it. AP and lateral frag view. So DDH is important. Why I mentioned and choose it today, because one of the things, if you diagnose it early, you will solve the problem. But if it's delayed, the child will limp all their life. Will cause non-reversible arthritis in the hip joint. But if it's diagnosed early, it's important. So DDH ranges from complete dislocation of the hip joint and the femoral head outside the acetabulum to dysplasia of the acetabulum. The acetabulum is too shallow to hold the head of the femur. So the risk factors, very important to be familiar with it, like breech position in utero, female sex. Like female, it was more common in female than boys, but boys they can also have DDH as well. First born. So if you have a firstborn female breech, this is a high risk. Other condition related to prenatal positioning, including metatarsus adductus. Metatarsus adductus means that the foot is curved to the inside. Other one is torticollis. So if you see a child born with torticollis, consider associated DDH with it. Very important. A child born with torticollis, very important to keep DDH. You have to screen. You have to screen. To do what? Ultrasound. So كنا زمان الناس كانوا بيربطوا الأطفال بالحبل صح؟ أيوه. ده يعني this is one of the causes of DDH. One of the causes. So how to swaddle the child? You have to allow it's okay to swaddle and to allow the feet to move freely, so they can move it. But if they do it with rabbit to the point, the child cannot move it. This is one of the causes of DDH. So improper swaddling is a risk factor. So الربط بالحبل ده مش كويس خالص يعني. So diagnosis in neonatal period, the best thing to make the diagnosis. Until now in the US there is no generalized screening for everybody. Diagnosed clinically. In England and maybe in Australia and some other countries, they have to do ultrasound for everybody. But in the US still you have to diagnose clinically. First, if you suspect, you do a Barlow or Tulane. Yeah. So hip ultrasound before 4 months, and radiograph from 4 to 6 months will show this dislocation. Ultrasound can show it in any age, yes. X-ray cannot show it in young age. Like if you do it X-ray for 2 months, will not show anything. There is no ossification center yet. So it's important plain radiograph at least to be 4 to 6 months to show the ossification center. So how to do the Barlow or Tulane? Barlow means that you are trying to dislocate, and Ortolani you are trying to relocate. So what you will do, you will push down, and you are trying to get the head of the femur outside of the acetabulum. So you do adduction, you hold the knees like that, and 4 fingers on one side and the thumb on the other side, and you do one on a time, one hand on a time. Don't do both at the same time. So you do 4 fingers, and this 4 finger touching the greater trochanter, and the thumb on the inner thigh, and to apply pressure gently, not to push hard. Yeah, because you don't want it to dislocate it yourself. Okay. So if it's dislocated, you will feel it's coming out with you, outside. Not click, clunk. Yeah, clunk. What is the difference between click and the clunk? Click, you will feel something, but clunk, you will feel it's out, it's coming, loose. And if you feel it once, you will never miss it. If you had one positive DDH before, you will never miss what is clunk. But click, everybody click. Like you do the finger, it clicks. So this is a click. This doesn't mean anything. So click doesn't mean hip dysplasia. The clunk means that you feel the head of the femur is coming out. And then in order to return it, you have to do the ortolani. You do outside, abduction, and will go inside. So if you feel the clunk, the head is coming out and in, you know this is obviously. Do you need to do ultrasound for that? Not really. If it's already coming out and you feel it, even if the ultrasound is negative, it's useless. So the best thing to do, orthopedic. To send to orthopedic. So orthopedic you trust. So the X-ray is not clear in this picture, but anyway, so this is the head of the femur. You see here, this is called the Hilgen-Reiner line. It's a imaginary line at the lower hip, so at the lower line here, you do this line like that at the lower end of the hip, and then you do Birkin line is perpendicular to it with the acetabulum, with the roof of the acetabulum, and you see this head here is coming or located in this area, which is lower medial. Here the ossification center is located far away, is located in the upper outer, So if it's normal, both of them, it should be here. So if it's normal, but this one is abnormal, it's already out, it's out of the area. So the clinical presentation positive Barlow or Tulane in toddlers if they are missed, and usually So if you, it's a good idea if you have a newborn coming to you because of fever, because of any other cause, rash, anything, just always examine the hip, even if it's not, just as a routine, because there is no routine health will visit here. For us, we have a child who has to come to me every year, and before 1 year of age, they come at 2 months, 4 months, 6 months. So it's very hard to miss it. But here is easy to be missed because as long as he's not sick, he will not come to see you. So if he comes to see you, I always examine and do fast exam to make sure I'm not missing anything. So the toddler. Yeah, but one clinician may miss it. This is very common. And then if it was missed during neonatal period and it goes to the pediatrician because of fever, they check the ear stuff, they will not examine. So this child will be diagnosed when they start to walk and they start to limp. Okay, so if it's one side, they will limp like that. But if it's two sides, they will be walking like a dog. Okay, and also may cause leg length discrepancy. Okay, and you will see limited abduction of the affected side. And of course, unequal gluteal line is suggestive, but it's not diagnostic. It's important because some kids they have unequal gluteal line and they are not DDH. So, and when I do, actually it's a habit. I do it all the time for all the kids who they are coming for any other reason. I flex their knees like that, and I check the difference in the height between both. So I do it, it takes a second. But if you see it like that, you put the feet in a flat surface, and you see one knee is higher than the other, this is abnormal. This is it's called the positive Galeazzi sign. But this will be positive only in unilateral DPH. But if it's bilateral, it will not show too much. Okay. The age? Before walking. Yeah, because if he start to walk, he will be limping. Yeah, he will be limping. But if before walking, like I have 9 months, he came and is not walking yet. In the physical exam, I do the Galeazzi to make sure I'm not missing DDH because it may be I missed it before, I didn't examine well before. So I always remind myself to examine and not to miss something serious like that. Because in the US, if someone has ADH, they will get the name of all the doctors they saw this child and they will sue them all. يعني كلهم هيروحوا المحكمة كلهم. يقولوا انت شفت ده وانت شفته وانت شفته فكلهم بيتبهدلوا يعني. So DDH screening. So if you have a risk factor but normal exam, like breech position in the 3rd trimester, or family history of DDH, and history of abnormal hip physical examination in neonatal period, or history of improper swaddling, or suspicious or inconclusive physical exam, you are not sure. You are not sure if it's a click or clunk. It happens all the time. So the best thing not to do ultrasound today. Don't wait till the child is 4 weeks old and do the ultrasound. Because if you do it today, when the child 1 day old, and the exam looks normal or suspicious, or there is a risk factor like breech position, so it's a bad habit to breech position, normal exam, and you do ultrasound in the neonatal period. Because it may give you false positive and you scare the family that the child is having DDH and is not having DDH. Repeat at 4 weeks. Or do it at 4 weeks. You don't need to do it. If the exam is normal and you know how to do it, no ultrasound. Do the ultrasound at 4 weeks. So the treatment is pelvic harness, and usually the idea of pelvic harness is to flex the knees 90 degrees and the abduction. And this will relocate the head of the femur in the socket and the acetabulum will start to form around and will treat the problem. And this can be used for 24 hours all day, and they change the diaper from this area, no problem. And usually they can wear it for 6 to 12 weeks. And of course, if it's missed, and the treatment is surgery. This is a 6-year-old boy presents with pain in the left knee. He has no history of trauma or fall. There is no fever or physical exam. Both hips exhibited limited adduction and internal rotation. Knees and hips shown swollen or erythema. Hip X-ray showed misshape, collapsed femoral head, and inflammatory markers are normal, what is the most likely diagnosis? Yeah, exactly. Perfect. Thank you. So it's a leg calf Burf's disease. Yeah, one of the causes history of taking too much steroids, sickle cell disease, unknown, idiopathic, we don't know the exact cause. So is a vascular necrosis of the head of the femur, and if your child all of a sudden, and the children, and this is the things about it is painless. No pain, and the most common age 4 to 10 years of age. So pelvic X-ray, also AP and lateral frag view. This is the best study. I will show it. So it can be idiopathic vascular necrosis. The exact cause is no long-term use of collocorticoid trauma or sickle cell disease. It's more common in boys and usually painless limb. So it's very important, and this is very common everywhere. The child will, if you have a child with any complaint of the knee, always X-ray the hip, especially if the knee exam is normal. The good things about this case is looks bad, but most of the orthopedic, they don't do anything, just they observe. Most of the self-limited and will improve with time. So this another one is important not to miss it. 13-year-old boy with right hip and knee pain, and for 2 weeks duration. He has been limping. On physical exam, external rotation of the affected extremity. Lateral radiograph showed both hips are abnormal. You see here this line, this head of the femur is slipped down, and this one is looks normal. So this line of the greater triquetral is dissecting one part of the head of the femur. So what is the most likely diagnosis? Which one? B. Perfect. So it's slipped capital femoral epiphyseal. So this can be stable, like the patient is able to bear weight or unable to bear weight. So both cases you have to notify. Most of the cases you have to admit them. They have to be admitted and or notify orthopedic immediately. Because if they walk on it without any support, it may cause further damage. So it's more common in obese African American between 12 and 14. They may complain of knee pain or hip pain or both. So not all the time will tell you hip pain. They tell you my right hip hurt and my knee hurt. Or sometimes they come with knee pain, and a lot of it happens everywhere. They go to the ER with knee pain. They do X-ray on the knee. Knee is normal. They send them home. They tell you just or referral to orthopedic. And orthopedic when they call come after 12 weeks or 3 months. But if you tell the orthopedic I have SCIFI or slipped capital, they will see the child right away. So the management is admission. Now we'll move to another cases. You have a child coming with blood in urine. What is the next step? The mom bring you a cup and or she told you or took a picture that the urine has blood. What is the next step? Like you didn't do anything yet. The mom said there is a blood in urine. What to do next?
Proper history. Proper history.
Proper history, physical exam. Yeah, urinalysis. So you have to do urinalysis. So I will tell you the approach here. So you have to do urinalysis, and when you do urinalysis, what to look for? If there is no red blood cells or there is red blood cell. If you have no red blood cells, you are dealing maybe with myoglobinuria, okay, or hemoglobinuria if there is any history of hemolysis, like paroxysmal nocturnal hemoglobinuria. Medication like Bactrim, for example. Food coloring agent like ممكن أكلين اللي هو البيتس اللي هو البنجر مثلا بيخلوا أو بعض الأدوية أو يوريت كريستالز. يوريت كريستال جايبه لك دايبر وفيها ايه؟ وفيها بينكش كولر، دي ممكن تكون ايه مش بلاد ولا حاجه، يوريت كريستالز. تمام؟ لو هي 5 or more red blood cells and there is cast, okay, and cooler color, no clots, and maybe positive proteinuria, this is called the glomerular hematuria. If it's no red blood cells, no dysmorphic red blood cells, and some plus or minus clots, maybe no protein or less protein, this is non-glomerular hematuria. So urate crystals is very common, not to miss it. This is reassurance. Just with proper feeding, more frequent feeding will disappear. This is a transient problem. No medicine whatsoever. So if you have a glomerular hematuria with red blood cell cast in the urinalysis and dysmorphic red blood cells, think about post-infectious glomerulonephritis, IgA nephropathy, lupus, Alport, membranoproliferative glomerulonephritis, Henoch-Schönlein purpura, hemolytic uremic syndrome. If it's no red blood cell cast and eumorphic, like normal shaped red blood cell, think about UTI is the most common. UTI is the most. So if someone tell me my child is having blood in urine, first thing to come to my mind is most likely it could be UTI. I will ask if there is any dysuria, frequency, urgency. If it's not, I can do urine culture. So UTI is one of the most common. Trauma, sickle cell anemia or especially trait, kidney stones can give you red blood cells in urine. You will have pain with it. Wilms tumor can do that. Polycystic kidney disease, meatal stenosis like bad circumcision. Someone did circumcision badly, and they can have meatal stenosis. They may present with blood in urine. Or renal vein thrombosis. Renal vein thrombosis is very common in neonates when they have sepsis, and they may present with blood in urine and the flat mass in the flank, unilateral or bilateral. So what to order? Lab to order for glomerular hematuria, CBC, complete metabolic panel, which is the renal and liver function, all electrolytes, cholesterol C3, C4, anti-DNase B. I didn't put here ASO titer because ASO titer is not the best for kidney. So you don't need to order ASO titer for kidney. It's good for the heart, but it's not good for the kidney. Throat culture, ANA. ASO titer will be positive if it's secondary to streptococcal infection. But DNA is a better test. It's a better test to use. Why? Because it will be positive in both. Will be positive in both, in streptococcal infection and the impetigo. ANA, if you suspect lupus, if you see C3 and C4 both low, urine protein to creatinine ratio, hepatitis C especially, and HIV. If you see epistaxis with hematuria, you can order anti-neutrophil cytoplasmic antibodies. I will not order this from the beginning, but if they have epistaxis with hematuria, think about granulomatosis with polyangiitis, or well known as Wegener syndrome, Wegener granulomatosis. Or if they have hemopsis, like coughing blood with hematuria, think about Goodpasture syndrome. So if you have this combination, you can order these. For non-glomerular, urine culture, urine calcium to creatinine ratio, I will explain why. Renal bladder ultrasound for kidney stone. Now the study of choice for kidney stone is renal bladder ultrasound, not CT scan. CT scan if it's missed, if it's not detected. But if it's detected by ultrasound, why to go for CT scan? 24-hour urine calcium, creatinine, uric acid. This will give you a study for different type of kidney stones. CT or cystoscopy if there is a trauma. KUB means abdominal X-ray. So you have a case here, a 9-year-old boy with recurrent hematuria associated with painful urination. Physical exam is normal. His labs are significant for presence of 20 red blood cells in urine, no white blood cells, no red blood cell cast, no crystals. Renal ultrasound is negative for kidney stones. And urine calcium to creatinine ratio is 0.6. Normal is 0.2. So this is high. What is the most likely diagnosis? Yeah, perfect. So this is the idiopathic hypercalciuria. So just to be familiar with this, because this is not rare, this is quite common. It may be inherited as autosomal dominant, may run in the family, may be associated with hyperparathyroidism, overuse of vitamin D, too much vitamin D, immobilization, loop diuretics, sarcoidosis, rare stuff. Clinical presentation may present with chronic gross hematuria or microscopic hematuria, dysuria. They may have painful urination. They may have diffuse abdominal pain. Diagnosis is to do, you can do urine, 24-hour urine. I can start with the spot urine calcium to creatinine ratio. If it's abnormal, you can do the 24-hour urine. And this is abnormal if it's more than 0.2 in older child, more than 8. But remember, this can be normal in infants, like less than 7 months. Can be go as high as 0.8, so it has to be higher than 0.8. So the treatment of idiopathic hypercalciuria, plenty of fluid, limitation of sodium intake. While limitation of sodium intake will increase calcium reabsorption and decrease urine in calcium. In significant cases, you can use hydrochlorothiazide and this will help to decrease the calcium in urine. So to summarize hematuria, next step to do urinalysis. If you have if it's UTI, do urine culture and treat. If it's no UTI, very important to do renal pelvic ultrasound or renal bladder ultrasound to rule out kidney stone, Wilms tumor, any source of blood. If you have hematuria non-glomerular and no signs of UTI, no masses, no kidney stone, do calcium to creatinine ratio. If it's more than 0.2, we mentioned it, right? Idiopathic hypercalciuria. Okay, if you have acute onset hematuria, glomerular means dysmorphic red blood cells, red blood cell cast, and you have elevated blood pressure, proteinuria, low C3, normal C4, negative DNAs, negative ASO titer. What is the most likely cause? انا حطيت نيجاتيف دي ان اي ونيجاتيف اس او تايتر مخصوص علشان الحته دي. ها؟ اها.
ممكن مع فيروس.
This could be, but there is something I want you to know it. Systemic lupus will give you low C4, systemic lupus. But here is normal. Huh? Reactive. هي ابسط، هي بسيطه، انت يعني والبيسر بقى هي بسيطه، كلكم عارفين الاجابه، بس انا عملت دي نيجاتيف عشان في الريل لايف you may have these tests are negative. بوست انفكشوس جلوميرولونيفراي اللي هي بوست ستريبتوكوكال جلوميرولونيفراي، بس الكوز ما هوش ستريبتوكوكس لانها can be caused by staph, can be caused by virus. That's why they changed the name in the textbooks from post streptococcal glomerulonephritis to post infectious glomerulonephritis عشان لما تلاقي الدي ان اي بي انتي بوديز نيجاتيف والاي تايتر نيجاتيف ما تبقاش كونفيوزد، يعني هي ستيل بوست انفكشوس جلوميرولونيفرايتس. ايه هو الموست كومن كوز؟ بوست ستريبتوكوكال جلوميرولونيفرايتس. اوكي؟ And the treatment is supportive. You manage the blood pressure, you manage fluids, and 98% they resolve with no problem. Okay, you have acute onset hematuria concurrent with URIs, with upper respiratory tract infection, and it's glomerular. Why? Because dysmorphic red blood cell count. Normal C3, normal C4, and they have some proteinuria. What is the most likely cause? Yeah, recurrent gross hematuria. Yes. What is the cause? IgA nephropathy. Excellent. So IgA nephropathy. So what is the next step to do renal biopsy? You will see the immune complex on the mesangium in the glomeruli, and this needs a long-term follow-up. They do not have. In the beginning they will not have kidney injury or renal failure. They may have it in the future. So they have to follow up with nephrologists all the time. If you have hematuria and it's glomerular and you associate with petechiae, abdominal pain and joint swelling. Thank you. Yeah, Henoch line purpura. So انا عارف انه كلنا عارفين الهينوكش لاين بيربرا يعني كلنا، بس المهم في الهينوكش لاين بيربرا اهم حاجه انك تفولو اب فور هيماتيوريا اور proteinuria. Proteinuria. So you have to follow up the patient for at least 6 months. Okay, so this is most important to monitor urinalysis and the blood pressure. So بيجوا العيادة periodically you monitor blood pressure والurinalysis. What you are looking for renal involvement, for proteinuria, to monitor for proteinuria, because there is a risk they may develop renal injury and you will see proteinuria up to 6 months after presentation, even if the initial urinalysis results were normal. So if you have Henoch line purpura and the initial urinalysis was normal, very important to monitor for 6 months. Okay, hematuria, dysmorphic red blood cells with red blood cell cast, and you have hearing loss, ocular abnormality, positive family history of renal failure and hearing loss. Yeah, perfect. Alport syndrome. So you will see one uncle maybe with renal dialysis. Okay, so you have also glomerular with renal dysmorphic red blood cell and absent patella and dysmorphic nails. So glomerular hematuria, absent patella and dysmorphic nails. هو ده رير قوي يعني، بس انا حطيته يعني ايه، هو اسم السندروم ميل باتيلا syndrome. So another one, you have hematuria with high BUN and creatinine, oliguria, mild proteinuria, anemia, high bilirubin level like hemolytic anemia, high LDH, low platelets, schistocytes, Coombs negative, HUS. So hemolytic uremic syndrome. Okay, this is very important. You may have in the history bloody diarrhea before, and it triggered the hemolytic uremic syndrome. You have hematuria with myoglobin but no red blood cells, and if the child is suffering from myalgia, generalized weakness, dark urine, hyperkalemia, and the hyperkalemia sometimes severe enough to cause arrhythmia, okay, and high CK level, and this may cause acute kidney injury. What is the most likely cause? Yeah, perfect. Rhabdomyolysis. Perfect. So don't miss rhabdomyolysis. Okay, like for example, heat exhaustion, heat stroke, some medicine, some trauma, accidents. These things can cause rhabdomyolysis. And you will see blood in urine, but when you do urinalysis, there is no red blood cells, just the myoglobin. So to summarize the hematuria, C3 and C4, if you have low C3, this is post-infectious glomerulonephritis. This is very important. And if it's post-streptococcal, is a good. You will see positive DNAs. Negative DNAs if the infectious cause is different. Low C3 and C4, lupus nephritis, membranoproliferative glomerulonephritis. C3 will remain low. If you follow up someone with post-infectious glomerulonephritis after 1 month or after 2 months, and the C3 is still low, this is a bad prognostic sign. So C3 should return to normal. And for normal C3 and C4, you would see that in idiopathic hypercalciuria, in IgA nephropathy and IgA vasculitis. IgA vasculitis, I mean Henoch-Schönlein-Berger. Okay, another one, the face of my child is swollen. So, first thing you think about, yeah, 2 years old or 3 years old with swollen face, so nephrotic syndrome. So if you have a proteinuria and the dipstick 3 plus or more, so before I start, any proteinuria more than trace is abnormal. This is the new guideline. They used to say 1 plus or 2 plus. Now anything more than trace is abnormal proteinuria. So if you have dipstick more than 40 milligrams per meter square per hour or more than 1,000 milligrams or 3 to 3.5, this is a nephrotic range. And urine protein to creatinine ratio more than 2.5 to 3, this is nephrotic range. So if you have the age, I'm not going to discuss nephrotic syndrome, I will just go over important things for us. If the age 2 to 6, you treat. There is no biopsy or anything. If this is a classic, minimally changing disease, you treat. But if you have non-classic, like if the age less than 1 and more than 10, or not responsive to steroid therapy, you refer to nephrologist for treatment and renal biopsy. They have to do renal biopsy to know the exact cause. Because it's unusual to have 6 months with nephrotic syndrome or 11 years with nephrotic syndrome. You have a healthy child with persistent proteinuria more than trace. What to do next?
Just follow up.
Huh?
Just follow up.
Follow up. Yes, thank you. Thank you. Yeah, she said to rule out orthostatic proteinuria or transient proteinuria.
Morning protein.
Exactly, morning sample. So what to do proteinuria less than 3 plus or more than trace, you do urine protein to creatinine ratio. If the ratio is less than 0.2, is orthostatic proteinuria. Reassure the family and repeat every year. So this is the to do. So the best study protein to creatinine ratio. Less than 0.2, orthostatic or transient, also the other name, transient proteinuria. If it's more than 0.2, repeat in 2 weeks. If it's still more than 0.2, it's persistent proteinuria, refer to nephrologist. If it's less than 0.2, it's transient proteinuria and just follow up. Okay, we did that before. My child is having anemia and not improving. We did that before. So if no symptom, physical examination is normal. You do CBC, serum ferritin reticulocyte count. That's it. This is the only you will order. You don't need to order more than that. So having anemia, not improving, and no symptoms whatsoever. So you do the Minzer index, as we mentioned before. Less than 13 and normal ferritin, this is thalassemia. And next step, reassurance. No further studies. No, you don't need to do, unless if the parents request or they need further investigation, but you don't need to do any further action. So the example here, if you have hemoglobin 10 grams, MCV 64, red blood cell 5.3, 64 divided by 5.3, 12. This is thalassemia range, thalassemia trait. So it doesn't matter if it's beta or alpha thalassemia, is still no treatment because the child doesn't have symptoms. No iron. No iron for a child doesn't have iron deficiency anemia, no need. So normal ferritin means thalassemia trait and reassure the family. And very important to know that if you do hemoglobin electrophoresis, will be normal in alpha thalassemia. So this is the electrophoresis, this is the normal, this is the origin, this is hemoglobin A2, this hemoglobin F is within normal range, hemoglobin A is within normal range. The majority of the hemoglobin A, which is the adult hemoglobin. In beta thalassemia trait, you will see the hemoglobin A2 slightly increase between 4 and 6%, hemoglobin F is normal, and the adult hemoglobin is slightly reduced. In beta thalassemia major, you will have still hemoglobin A is abnormal, hemoglobin A2, 4 to 6%, a lot of hemoglobin F between 30 to 95%, and zero, near zero adult hemoglobin, that's why they are very sick. So if you have iron deficiency anemia, ferritin will be low or high? In iron deficiency anemia? Low. And TIBC? High. And the soluble transferrin receptor level will be high or low? Will be high because looking for iron, and this will be high. Transferrin is looking to carry any iron. And the iron itself is low or high? Low. And so transferrin saturation will be low because there is no iron to catch. They trying to find any iron. These are the carriers. There is nothing to carry, so the number will be high. And this one is the iron is low, and the transferrin saturation will be low as well because there is no iron to carry. Okay, so you will have low ferritin. Whenever the ferritin is low, TIBC is high. Soluble transferrin receptor and the transferrin, they will be elevated. Why? They are trying to catch the liver producing too much transferrin protein, trying to catch any iron in the circulation to make more hemoglobin, but there is none, so they will be elevated. And the iron is low, there is nothing to carry, so the transferrin saturation will be low, which is this transferrin is not saturated with iron, is deficient. So in anemia of chronic disease, you will see the ferritin low or high? High, exactly. And TIBC? Whenever the ferritin is high, TIBC will be low. Okay, and everything else will be low. Low iron, low trend, because iron is already trapped. The body has iron, but it's trapped in the reticuloendothelial system because of the inflammation. So iron will be low, transferrin saturation low, transferrin is low. So treatment of iron deficiency anemia, the dose is 2 to 3 milligrams per kilo of elemental iron per day. And the once a day is better than twice or 3 times a day. And usually it's better to be in empty stomach with orange juice or anything acidic. Okay, I think كده هتطول كده كتير كده صح؟ أكمل؟ My child is not speaking. What is the next step?
Hearing
Yeah, perfect. Thank you. So not all children with speech delay, they are autistic. This is most of the parents, when they say a child not speaking, they think he's عنده توحد. يعني is not. This is not common. It's most common to see speech delay by itself without autism. So if no other developmental delays, normal physical exam, do audiology test and start speech therapy. You can do at the same time. You don't have to wait for the audiology to start speech therapy. وديهم مكان فيه تخاطب يتعلموا الكلام. My child is not acting like other children at his age. What is the next step? He's not acting like the mom is concerned. He's not acting like normal like the kids at his age.
يعني ايه كومبلين اصلا؟
ها؟
هو ايه مشكلته؟ مش عارف.
مشكلته ان هو يعني مش بيلعب مع الاطفال، ما هوش زيهم، ما هوش في الليفل بتاعهم، شكله يعني اصغر من سنه. Yeah, so the best thing to do clinical evaluation, including history and physical exam. You check the eye, you check the ear to make sure that there is no problem. You check the vision and the hearing test. So for any child developmentally delayed, like developmental milestone delayed, ما هي الام مش هتيجي تقول مثلا my child is developmentally delayed، يعني هتقول بس انا حاسه ان هو مش متطور زي بقيه الاطفال، حاسه ان هو كده اقل من الاطفال التانيين، فده developmental delay. فهاو to do it: number one, physical exam to make sure there is no syndrome or anything. Check vision and the hearing. You do ages and the stages questionnaire. I use that all the time, and is helping me personally in my clinic to detect a lot of developmental delay, and they are available in Arabic. So ages and the stages questionnaire. If you suspect autism, if the child is 3 years and older, you can do CAST questionnaire, and they are available in Arabic. And the parents, they can fill them out, and you can have your diagnosis in 15 minutes. Okay, or chat for children less than 3.
ages and stage questionnaire دي ايه معلش؟
ها؟
دي اللي هي الاي كيو هنا عندنا اللي هو بيعمل مستوى
ده
الذكاء.
questionnaire they ask about motor skills, speech, language skills. They find motor,
الاي كيو
social motors اللي هي الاي كيو. But it's called the ages and the stages questionnaires. It's developed by American Academy of Pediatrics, and they are in all ages. So you want to know about autism, or you want to continue, or it's too much? Because the time today is yes. Everybody yes? Okay. Okay. So autism. The message today for autism, that is a clinical diagnosis, no lab. Because I see some people, they send me labs from here, or especially in السعودية والبلاد الثانية. لابس في يعني
خبر وسيرين بيعملوا معايا
كل ده ما انزل الله به من سلطان، يعني ما فيش لاب بيعمل دايجنوسيس لاوتيزم. از نوت ذا ستاندرد فبيقعدوا يعملوا تيست الفيتامينز غريبه جدا وفيتامين نادره جدا، ويكلفوا الاب والام تكاليف بايظه، وفي الاخر الحاجات دي ما هيش ستاندرد اوف كير، لان هيدوا للاب للابن علاج هو مش محتاجه او مش هيفيد في حاجه يعني. فهو up to date today the autism is a clinical diagnosis. There is no, you have just a questionnaire and the clinical evaluation and the observation. So it's impairment in social interaction. The child is not socially, he's isolated. He's not making eye contact. He's not pointing. He's by himself. So restricted range of interest. He's not interested in anything. So proto-declarative pointing is not pointing like 18 months وعيل عنده سنه ونص وما ما بيبص العربيه، بص ده ما فيش اي pointing، ده red flag. Environmental stimuli, they are like sensitive to noise. بس these things by itself in isolation، يعني مثلا طفل اول ما يسمع صوت المكنسه مثلا يعيط، ده مش معناه ان هو عنده اوتيزم، مش لازم يعني هو بيتكلم كويس بس هو مش حابب الصوت ده، ف it has to be combined with a lot of things. It's not just one thing by itself. Social interaction, this is the most important one. Most important thing or diagnostic point for autism: the child is not socially interactive, is not making eye contact, he's just in his own. So how to make the diagnosis? To do chat for young children, or you do CAST questionnaires. Of course, there is many other questionnaires you can use, but this is one is common and is easy to use and is available in Arabic too. And if both are positive, you can refer for treatment. So you get that. So chat for less than 3. CAST is questionnaire and observation. Of course, if you have a psychologist specialized in autism, you can refer to this psychologist or this specialist, because they can do more observation, evaluation, and more, because it takes a long time. It may it's called in the US, it's called EDOS. They observe the child for 3-4 hours. They give them a lot of toys, a lot of things, and they see if they have it or not. But if you have limited resources, you can use the CAST questionnaire, and then if it's positive, you can refer for treatment. What is the treatment? Applied behavioral analysis. This is the most effective for treatment of autism. Applied behavioral analysis. So, and if all of us will start to request it, they may train people to make it here available, so they are able to treat autism. Speech therapy if speech is delayed, and occupational and physical therapy if it's indicated. So especially physical, if there is any problem with physical, with fine touch or anything like that, they can do physical therapy with occupational therapy. But applied behavioral analysis is the best. What is applied behavioral analysis؟ هو زي بيدوا الطفل بتخليه يعمل حاجات complex task بس بتقسمها له كده to break it down for him. You bring something and then when he bring it you give him a reward and then they advance slowly to make it more complex task. تمام؟ بس يعني فهي لها personnel بيكون trained وحتى في in the United States they train the people to do applied behavioral analysis very limited and is extremely expensive. So if they have a child with autism and is hyper going around and is hard to stay still, you can use risperidone is available here in Egypt, or aripiprazole or Abilify. I'm not sure if this is available. This one is one of the drug of choice. Is FDA approved. If you have someone with autism and is aggressive, like to hit other children, or cannot stay still or very active, you can use risperidone. So when to do genetic testing for someone with autism, if there is has intellectual disability or abnormal exam, you can do fragile X DNA analysis and chromosomal microarray analysis. This is the one if they have intellectual disability. But actually, a lot of kids with autism are extremely smart. They are some of them are genius. Okay, so it's just they have problem with this to socialize with others. They have a problem to make eye contact. So some kids are really smart and they have autism. They need a little bit of training, a little bit of behavioral intervention, and then they will be okay. So if they have developmental like intellectual disability, you can do, because fragile X, there is no specific sign of fragile X in young children. They don't have this large ear and all of that. These things develop later when they are older. So fragile X when they are young may be the only presentation, intellectual disability and autism. That's it, no other symptoms. My child is hyperactive and not doing well in school. Yeah, so possibly the mom is referring to ADHD, right? So what to do for ADHD? Clinical evaluation, developmental evaluation, check the vision, and to provide them with Vanderbilt for ADHD by parents and teacher. You have to diagnose it in two situations. No labs to make the diagnosis of ADHD. So I will go over it quickly. ADHD in attention, hyperactivity, and impulsivity. So the child doesn't pay attention, careless mistakes, easily distracted, just moving too much, cannot stay still, active, يعني زي ما يكون جواه موتور ما يقدرش يقف. تمام؟ So the theory behind it, they said the most likely, the exact cause is unknown, but the most common theory that decreased dopamine or norepinephrine in these children, and this will decrease the attention, arousal, and impulse control. The red flags of ADHD: declining academic performance, relationship difficulties, and symptoms of emotional problems. So how to make the diagnosis? There is no single test. It's a clinical evaluation. You interview the child, you interview parents, and you make your diagnosis. So the best thing to use Vanderbilt. This is the one of the choice, and it's available in Arabic too. You give one copy to the parent and one copy to the teacher. But the most important point, you have to be familiar with disease. They may give you ADHD-like symptom, but it's not ADHD, like sleep apnea. So the child is not sleeping well. Different in young children, like for me, if I don't sleep, I will feel sleepy all day. But for a young child, they may be actually the opposite. They are just too hyper during the day because of lack of sleep. So sleep apnea, like one of the things when I have a child with ADHD, possibility of ADHD, first thing I look at the tonsils. If he has large tonsils and the adenoid, this may be actually. So if they remove the tonsil, if you prove they have sleep apnea, and they are hyperactive because of lack of sleep, removal of tonsil and adenoid might solve the problem. It's not ADHD. Poor sleep hygiene, sensory impairments, so poor vision, so you have to check the vision. Iron deficiency anemia, if the child look at the nail, look at the lips. Seizures, like absent seizures, inappropriate school placement, unrealistic expectation, the parent that expect too much from the child, and anxiety, mood disorder, specific learning disability or intellectual disability. These things are not ADHD. ADHD actually, most of them are really smart, but just they cannot stay still. So you have to associated syndrome Klinefelter can be associated with learning disability. Fragile X can be associated with ADHD and even autism. Turner syndrome, DiGeorge, other rare causes. So how to make the diagnosis? 6 or more of inattention or hyperactivity, impulsivity, or both. 6 or more. If you have 6 from here, or 3 from here, and 3 from here, you have combined type. If you have 6 from here, inattentive type. If you have 6 from here, you have a hyperactive type. So you can have, it's called ADHD, hyperactive or inattentive or combined. You need just 6 from the list of the symptoms on Vanderbilt. Vanderbilt is questionnaires. Questionnaires. The parents will answer and the teacher will answer, and this will give you the diagnosis. It's called Vanderbilt. Have you ever used it before? Vanderbilt? Vanderbilt we use it all the time.
احنا بنبعتهم يا فندم للمتخصص او السايكاتريست او كده، هم اللي بيعملوها.
هو المشكله ان في امريكا في ما فيش يعني مثلا المدينه اللي انا فيها مفيش غير واحد بس. فممكن الابوين بتاخد سنه او 2. فاحنا مضطرين نعالجهم. فعشان كده يعني. Management of ADHD, behavioral interventions, school accommodation. You give them behavioral therapy. Behavioral therapy if they are less than 6. If they are 6 or older, you do the stimulant therapy. The stimulant therapy we have methylphenidate and amphetamine. This is the 2 types of medication we use. Is like, for example, Concerta. Concerta is available in Egypt, so you can use it for management of ADHD. And use it once a day in the morning, never at night. Because if you give it at night, they will never sleep. بس كده. Some spot diagnosis. Do you know what is the diagnosis of that? Huh? Yeah, what to do next? Yeah, I just put it for the most common now. What did you say? Huh? Renal association. Yeah. Okay. So for that, you don't need for the treatment for that or the management of that in a newborn with ear tags or bits like dimple. You don't need to do ultrasound unless. So pre-auricular, it's called the pre-auricular pits and the sinuses or tags. Renal ultrasound should be performed in children with ear anomalies, accompanied with any of the following: other unknown organ malformation, like other known organ malformation, or family history of deafness, or auricular and renal malformation, like for example absent ear or cauliflower ear. But just a tag or dimple or sinus, you don't need to order ultrasound, or maternal history of gestational diabetes. So otherwise you don't need to order anything for that. So this is the new guideline. We used to order renal ultrasound routinely for all ear tags and sinus, and as long as good urine output, no family history of deafness, and the child passed the hearing screen before discharge, you don't need to do renal ultrasound. It is not indicated. But if any positive history or positive, like the child urine output is bad, hearing test is failed the hearing test, you can order the renal ultrasound. What is the diagnosis here? Yeah, umbilical hernia. What to do? ولا حاجة. أنا حطيت دي هنا لأني زعلان من يعني one family they told me. Yeah, it was one smaller than that, like almost like a quarter of this size. And the pediatrician here in دمياط قال لها ايه تروحي للجراح. فزعلت جدا يعني ليه توديه للجراح يعني؟ طب افرض الجراح قام عامل العمليه، طب يعني سبحان الله زعلت جدا. This is just observation. Usually surgery is indicated if it's worse after 1 year, and or is not resolved by 4 to 6 years. So most of the surgeons they don't touch these children. They wait. Either umbilical or para-umbilical hernia. Like if you have it here or on the side. So a para-umbilical hernia also is still observation. Which hernia you have to treat immediately? Inguinal. Yeah, inguinal hernia, no way. Especially if it's a female. Yeah, and so both of them, inguinal hernia, boys and girls, refer to surgeon as soon as possible. دي بقى اللي لو عملنا دي يبقى كويس جدا. My child has a curved leg. What to do next? ها؟ Yeah, examination is normal, walking normal, no limping, no signs of vitamin D deficiency, nothing. ها؟ Observation. Do nothing. Curved legs or neck or bow leg is a manifestation of vitamin D deficiency, but it's more common to be isolated, not vitamin D deficiency. So you have to explore about vitamin D deficiency. It is not, you don't have to do anything. So because I saw a couple cases, one in Alexandria, the child is having a curved leg and was giving too much vitamin D, too much calcium, until he developed nephrocalcinosis. And he did not need anything. You know?
طب ايه الشرط بقى بوينت اللي تعرفنا ان هي كده نورمال مش
It's coming.
طيب.
Okay, so you put the feet together. You put the feet together. If you do your fist and your fist passes through, this is significant. This is significant. If it's less than, I will tell you, more than 90% they are less than the size of your fist. This is for the bow leg, and if you have knock knee, you just put your fist here. If it's less than the size of your fist, you don't need to do. Huh?
If more than 4 سم
دي احسن كمان 4 سم. Yeah, المهم if it's not too big, you don't have to do anything. If there is no vitamin D deficiency or anything like that, you don't have to do it. The reassurance, geniovalgum is one of the benign things you see all the time, and no calcium, no vitamin D to be given unless it is deficient. If it's deficient, it's a different story. You do.
عايزه المانوفر تاني عشان يبقى واضح بس الكل. بنعمل يا حضرتك نعمل ايه؟
بتضمي رجلين الطفل بتضمها كده، تمام؟ لو هو مثلا نقول جينيو فيرم الرجل كيرف، بقوم اضممها من تحت وحاطط ايدي. لو ايدي دخلت ما بينها دي تو ماتش، تو بيج.
لازم يبقوا لازقين في بعض. الكالكينيا بتوعنا
بالظبط، لازم الماليولس تكون لازقه في الماليولس، تمام؟ بس لو عنده ناك ني اللي هيبقى لازق ايه؟ النيز. فبرضه احط ايدي تحت هنا، لو ايدي عدت ده كتير، فممكن تبعت لي الاورثوبيديك يبص عليه يعمل اكس راي علشان يرول اوت بلاونت ديزيز اور and the best thing to rule out to rule out vitamin D deficiency, you can do just the X-ray on the knee itself. This is the best site to do X-ray in the knee, vitamin D level and alkaline phosphatase. That's it, and you will know if it's vitamin D or not. So these are physiology. حاجة تانية, my child is walking with feet like this, walking like that. So what to do next? And she's sitting W like that. What to do next? Exactly, yeah, wait. So for that, you know surgery. Because actually to do surgery, they have to break the bone and they change it. So most of the orthopedic are reluctant to operate on kids like that because most of them, they improve by 12 years of age. So most of them, they wait till age of 12. Yeah, so they تلبس الشوز بالمقلوب, ده من ضمن الحاجات اللي بتتعمل. Yeah, but with the research, with the studies, show that they are not effective at all. To wear the shoes in the opposite or to wear orthotics. Sometimes they send them to wear orthotics to make their legs straight like that. So these things are not effective. So
يسيبها كده 11 سنة دول.
بس reassure the family, tell them nothing. Yeah, because it's a major surgery, and if it was done early, like at age of 7 or 5, is a big mistake. So most of the surgeon in the US, they delay till age of 12. Okay, so if the child, for example, doing sports and is falling too much and it is affecting their life, they trip a lot, بيقعوا كتير، بيتعنقلوا كتير، دي قصة تانية. انما لو ماشي كويس وبيلعب كويس ما حدش بيعملوا السيرجري، لان ممكن يحصل له مشكلة من السيرجري فيخافوا يعني.
بس لازم اشوف الفلوس عشان الميتاتارسس ادكتس.
ايوه الله يفتح عليك. الميتاتارسس ادكتس من ضمن الحاجات اللي بتعمل انتوينج.
يعني دي ما ينفعش استنى.
الميتاتارسس
ادكتس لو هي ريجيد حولها على طول.
ميتاتارسس yes, this one need to be referred. For intuing is reassurance. So this is the way to do the test. You ask the girl or the boy to lay in their tummy and you open their leg, you will feel normally they will be 45 degree like that, but it will open to 180 degree. This is positive. So this is normally it will be like this, but now you see it's open all the way. This is a positive femoral antiversion. It's called the excess femoral antiversion. So intuing can be caused by excess femoral antiversion, internal tibial torsion, or metatarsus adductus. So if you have also another cause of intuing to the child to walk like that is internal tibial torsion. It's different than so you ask the child to lay on the table and you flex the knee like that and look. If it's looking the foot is looking outside, this is normal. If it's looking inside, this is abnormal. This is called the internal tibial torsion. And what to do for that? Nothing. Just to reassure the family. No, almost no surgeon will operate on these kids to do that because it's almost self-limited and will disappear with time. So it's called the internal tibial torsion, one of the causes of intuing. Okay? And also حاجة تانية الأب والأمهات بمناسبة الفوت يجيب لك طفل عنده مثلا عنده سنة وتقول لك عنده flat foot. This is normal. The foot arch will form at age of 8 years. So it takes time for the foot arch to form. So there is no flat foot in young children. All of them normally they have, all newborn they have flat foot. Okay, and the arch will form as they grow. And almost done. Anyone knows the diagnosis of that?
الفلات فوت هنا ممكن في مصر بتوع العظم يعني من بدري بيعملوا لها دايجنوز.
No flat foot before age of 8.
8 سنين.
8 سنين. Flat foot is two presentations, pinless or painful. Pinless flat foot means flexible, means nothing, do nothing, no treatment.
لو البني من اول
لو البني yes. It's called the tarsal coalition. If you have painful flat foot like me, or someone, a boy or a girl has flat foot and every time they run they have pain, you ask him to stand on their tippy toe. If they do not make the arch and it's still flat, you order X-ray on the foot. If you see the tarsal bone is united together, this one needs a surgery. It needs to go to orthopedic. Yeah. But flexible, huh?
يلبس شوز طبي بيريح في المشي في الكلام ده كله.
ايوه.
بالذات للحاجه
الفلكسبل ايوه بالظبط. Flexible flat foot, you just wear a nice shoes with curve or insert. You apply insert for flat foot will make the child comfortable. We're almost done. We have 2 more slides. Anyone knows the diagnosis of that one? Huh? No, it's not cutis ablation.
انا وشي فيك.
ها؟
انا وشي.
You ask the child to stand on tiptoes, and when they stand because when they are standing like that, you will not see the curve. But when you stand in your tippy toes, you will see the curve. If the curve is formed, this is flexible flat foot. If the curve is not formed, this is a rigid one. This is the actual flat foot. And if it's painful, you have to do X-ray to rule out tarsal coalition. You know? But anyway, just to summarize, flat foot you don't need to treat or do anything unless it is painful. The first step in painful flat foot, like comfortable shoes with curve or insert. And if it's tarsal coalition, this is surgery. And this is rare. This is extremely rare. The most common, just the flat foot with needs a comfortable shoes with curve or insert. If you want to diagnose it, you just ask him to stand in tippy toes and you will see the curve is formed. This is flexible one, it's not the rigid one.
alopecia بس تروماتيك.
ها؟
alopecia بس تروماتيك.
Alopecia, this is a newborn. newborn.
تروما او
No trauma. Newborn is just fresh, and the mom, the baby was born like that. And I had like 3 children with this case. Huh? حد اسمها؟ Okay, so it's called the nevus sebaceous. You will see the skin is like orange skin, like area without hair and orange in skin. It's called the nevus sebaceous. Okay, nevus sebaceous. Huh? Nothing. Just you ask him to follow up. Every time they come, you look at it to make sure there is no change, because there is a small change to be malignant in the future. So when they are adolescent, the dermatologist may give them a choice to remove it surgically. It's called the nevus sebaceous of Jellison. So,
في العرش ميلانوما
ها؟
في ميلانوما كبيره شويه في الترانك.
دي لازم تروح فولو اب مع درماتولوج، لان اللارج نيفس بيبقى فيه تشانس ان تبقى مالجنت.
يعني عند عمر ايميديت؟
ها؟
ايميديتلي؟
لا دي مش I need to look it up. I don't know. This is the one. This is cutis aplasia. Cutis aplasia no skin. Cutis aplasia no skin. But you see the one nevus sebaceous has skin. So this is cutis aplasia. Anyone remember the syndrome associated with that? Yeah, Patau. Yeah, perfect. So cutis aplasia congenita. Anyone knows what is the diagnosis of that? And yeah, this child had a streptococcal infection before, and all of a sudden it has this rash all over the body. Huh? Gyanotic yeah, this one is called Goutet psoriasis. Goutet psoriasis commonly comes after streptococcal infection and disappear by itself with no treatment, no medicine. Rash for 3 weeks and not responding to treatment. The last one. Yeah, Pediatrics rosea. Okay. Let's say this one. This is Pediatrics rosea. You will see like rosy rash, and the long axis is taking the cleavage of the back, and they spread a lot. And but it's just as confusing when it comes in the beginning, like just one. If it's just one like that in the beginning, always misdiagnosed as tinea corporis. Yeah, tinea corporis. But tinea corporis is different. The edge will be raised, the center is clearing. This one, the center is always red and multiple, and is longitudinal. And it's and there is a scale there. The scale there, yeah, but it is not clear here. But this area it has a small scale, and you will see the spread. They are close to each other, clustering all over the body. But the tinea corporis is just 1, 2, 3, and far from each other, and well demarcated with raised edge. Okay, so you can visit Springer website and do Springer website. You can say Springer website Osama Naga, and you are able to download the textbook, the most recent copy, for free. Is by American, is by Egyptian Bank of Knowledge. You are able to download it for free. I did all my lectures from this book, and also you have at the end of this book about 2,500 clinical case scenario with immediate answer. So 2,500 clinical case scenario with immediate answer. You are able to download just this case by itself, or you download all of them for free. Once you are logged into Wi-Fi here in Egypt, it's free by Bank of Knowledge of Egypt. جزاكم الله خيرا وإن شاء الله
حد يولع الضوء لو سمحت.
يعني مفيش كلمات نقدر نعبر فيها.
يولع الضوء لو سمحت.
شكلنا دمياطي اصيله وصحيحه من
طيب من السراج.
ايوه من السراج المنير.
اسمها قضيه السراج مش السراجين.
أضيء القاع.
بأمانة تعجز الكلمات ان احنا نعبر عن يعني شكرنا وتقديرنا للاخ الفاضل الدكتور اسامه نجا، وربنا يجعله في سبيل حسناته وينفع به يا رب ويجبره عليه يعني كل خير. ساعدنا واستمتعنا واستفدنا بما فيه. المحاضرات دي كلها مسجله طبعا فيديو وكلها مع دكتور صباح، بس هي كانت عادي تنزل لما الكورس يخلص وتبدا بقى تنزل، فعملنا من النهارده ان شاء الله تنزل ان شاء الله. يعني اقل تقدير درع من الرابطه للاخ الفاضل الاستاذ الدكتور اشرف، الاستاذ اسامه نجا، الاستاذ اشرف.
ممكن يا دكتور اصلا قدام